you are what you eat. And this is supposed to be a good picture of a taco pizza. This was a 63-year-old woman who joined her family in a restaurant up north of the river and ate a taco pizza on June 19th of last year. And about a day later, she developed a flu-like illness and started having diarrhea, fatigue, malaise, loss of appetite, and dark urine. And over the next 10 days, her diarrhea continued to get worse, and eventually she noticed that she was having decreased urine output. It was also interesting that her daughter said that two of her children had also developed a mild self-limited case of diarrhea after visiting this restaurant. So eventually this woman started feeling bad enough that she went to her doctor, but it was 14 days after the onset of her illness. And at that time she appeared very pale and very weak and hemodynamically unstable, and so he immediately admitted her up to Berry Road for hydration. Her past medical history really didn't reveal anything that might predispose her to this type of a condition. She had fibromyalgia, depression, migraine headaches, things like that, but nothing that would suggest that she would be predisposed to what happened to her. On admission, she had anemia. Hemoglobin was 8.3. Her platelet count was down to 35,000. She also had elevated LDH of 1,000, and her haptoglobin had dropped down to 2, so there's good indication that she was hemolyzing. She was in renal failure. Her creatinine was 3.5 and her BUN is 70. And then I also think it's useful to sometimes point out what normal lab results were. She had a normal liver function test, and she had normal serum electrophoresis, so these findings of anemia and thrombocytopenia weren't being caused by any type of liver disease. Her anti-nuclear antibody, lupus anticoagulant, and direct antiglobulin tests were all negative, so this probably wasn't an autoimmune type of hemolysis. Her coagulation panel was normal, so the low platelets probably weren't being caused by DIC. Her fecal occult blood were all negative, and she had no evidence of fecal leukocytes, so this probably wasn't due to a GI bleed consuming platelets and red blood cells, and it probably wasn't due to an inflammatory bowel disease. Her bacterial stool culture was negative. Her ovum parasite exam was negative. She was negative for Clostridium difficile, Giardia, and Campylobacter, which are the most common causes of a diarrheal illness. They did test her for Shiga toxin, but it wasn't until 14 days after the onset of her symptoms, and it was negative. And they also ordered the Adams-13 enzyme, which is often low in patients with TTP, and it was normal. This was a peripheral smear that we saw in the laboratory, and you can see that, first of all, there's hardly any platelets in this high-power field, and we should see much more than just one platelet. And her red cells showed a lot of these fragmented cells, which we call schistocytes. And she had about 2 to 3 per high-power field, and so that's worrisome that she had a diagnosis of TTP. So the working diagnosis, after ruling everything else out, was that she had either TTP or HUS, TTP being thrombotic thrombocytopenic purpura and HUS being the hemolytic uremic syndrome. Most physicians just lump these two together, and I'm going to kind of show you why we differentiate them in some cases as we go on here. They started this patient on steroid therapy, even though there's really no evidence-based medicine that proves that prednisone is useful in these kinds of cases, but almost everybody uses it. Patient was transferred down to the plaza for daily plasma exchanges, and they started exchanges of about 60 milliliters of plasma for every kilogram of body weight. And so with this patient, she was getting about 10 units of FFP for every plasma exchange. And then she had 20 different plasma exchanges between June 30th and July 30th. She had a total of 200 units of plasma over that time period. Also, it was necessary to transfer with 4 units of red cells during this time. And as typical in these cases, they monitored the platelet count, the LDH, hemoglobin, creatinine, electrolytes, and calcium throughout her treatment. This just shows you a typical cell separator that we use for plasma exchanges, and the whole mechanism of this is that you take whole blood out from the patient, you spin it in a centrifuge bowl that's inside this machine, and the red cells and the platelets are denser, so they come out to the periphery, and then you can aspirate off the plasma and remove the plasma and discard that, and at the same time you can give back transfused plasma to the patient while this whole process is going on. And the reason you want to do this is to get rid of any kind of abnormal autoantibodies or toxins that might be causing the TTP or the HUS. And during the course of this patient's treatment, the brown line here is her platelet count, and you can see that it started at around 30,000, and after about 5 exchanges started to go up. And as typical in these cases, as the platelet count goes up and you start to taper off the therapy, not doing it quite as often, it'll start to dip back down, and then you'll have to continue your exchanges, and then eventually it goes up to a normal count. The other thing you'll notice is that the LDH typically drops, and it usually drops much faster than the platelet count goes up, but most physicians will follow both the platelet count and the LDH to determine whether or not the patient's responding to the treatment. In this case, the patient also had significant acute renal failure on admission, and the brown line just shows her creatinine starting out about 3.5, and then after about 4 exchanges going down to 1.5, and it took almost a month for it to get down to a level of 1.0. The blue line is just the calculated GFR, but it's really no different than just looking at the creatinine. I mentioned that people tend to lump TTP and HUS together. This is just a table that contrasts and compares the two. You can see that in both TTP and HUS you have anemia. You're more likely to have severe thrombocytopenia in TTP than you are in HUS, but usually they're both present to some degree. TTP seems to affect the brain much more often than HUS. Both cases sometimes have fever. It's not a really good indication that they have TTP. The big difference here is that in HUS it seems to involve the kidneys, whereas in TTP it's usually more the brain. Platelet counts are usually lower in TTP, but in our case the patient did have a low platelet count of 30,000. Again, reflecting the renal disease, the creatinine is always higher in HUS. I mentioned that Adams 13 enzyme that was tested. This is an enzyme that's typically low in TTP, but it's almost always normal in HUS. What a lot of people now say is that anytime you have a TTP-like disease and it follows a diarrheal illness, then you should call it hemolytic, the HUS, or hemolytic uremic syndrome. And that's sort of this classification that I prefer. As far as the kidney damage that occurs in HUS, what's really happening here is that this is the glomerulus of the kidney where all the blood is filtering through to make urine. And if you can see from back there, there's all these little red thrombi throughout all the capillaries of the glomerulus. And that's because blood clots are forming within all the small capillaries of the body in this disorder. And that's causing the hemolysis of the red blood cells and resulting in the red urine that you see in these patients. So typical findings are a low platelet count, a low hemoglobin, a high reticulocyte count because the bone marrow is trying to respond to the anemia. You see the schistocytes because the red cells are being sheared as they try to pass through these small blood vessels that have blood clots in them. The LDH is high because you're destroying both the platelets and the red blood cells. The hematuria occurs because the red blood cells are being sheared as they go through these small capillaries, especially in the kidney. Bilirubin is increased simply because you're releasing so much hemoglobin from these ruptured red cells, and the liver is then converting it to the bilirubin. Haptoglobin is decreased because that's our main safeguard in our circulation to bind up free heme and iron, because those are toxic. And so as they bind up the iron, it's immediately cleared by the liver. And then the Adams 13 enzyme level will be decreased in TTP, but as I mentioned, it's usually normal in hemolytic uremic syndrome. As far as what's happening in these two diseases, in TTP, typically the platelet thrombi occur in all these small arterioles and capillaries and decreased blood supply, especially in the brain. That's what causes the neurological symptoms. Red cells are then destroyed because they're trying to pass through these blood clots. And typically these patients start having this disease because they form an autoantibody against this Adams 13 enzyme. And that enzyme is what breaks up von Willebrand's factor. And if that doesn't happen, you get these huge aggregates of von Willebrand's factor and platelets forming in the circulation. And that's what leads to these blood clots. But in hemolytic uremic syndrome, what happens usually is that E. coli invades into the GI tract and damages the lining of the colon, and then releases a toxin called the Shiga toxin, S-H-I-G-A. And that this toxin then damages the endothelial surfaces of small blood vessels, especially in the kidney. And then once that damage occurs, the platelets come and try to repair that, but often it results in thrombi forming. And then that results in the shearing of the red blood cells and the destruction of the platelets. So these E. coli that produce the Shiga toxin are called Shiga toxin producing E. coli, and a lot of people just abbreviate that STEC. They can be subtyped, and most commonly it's caused by these E. coli that are called O157H7. And about 85% of cases are caused by that, and about 15% of the cases are caused by other E. coli that produce this toxin but aren't O157, so they're just called non-O157 strains. Patients typically present with abdominal pain, a hemorrhagic colitis, and that results in the bloody diarrhea. There's about 100,000 cases per year in the United States of STEC, and about 3,000 of them are severe enough that patients are hospitalized, and about 90 patients a year die from this illness. Usually the illness starts to occur 3 to 7 days after exposure. Our case was a little atypical because the woman started having pretty bad symptoms within 2 days after she ate that pizza. She had, it's a striking organism because it only takes about 10 to 100 organisms to cause this kind of illness. And you can contrast that to cholera, which takes over 1 million organisms. So this is a very low infectious dose. This is most commonly occurs in children under the age of 5. Our case was kind of interesting because there were 2 kids that were affected, but they had a very mild illness, and it was the adult that got the really bad illness. It's most common in the summer months, and we see that here. We see our TTP season is usually summer into fall. And about 8% of the patients that get infected with these Shiga toxin E. coli will go on and develop the hemolytic uremic syndrome, so it's not rare. This toxin and these bacteria usually occur because of consuming contaminated water or food. It's most common in uncooked beef, unpasteurized juice, raw milk, and some fresh produce. CDC most recently showed some case studies that mainly involved lettuce, spinach, and alfalfa sprouts. It can occur through person-to-person contact. And it's usually in those situations where you have close contact with amongst people and you have substandard hand washing. And so it most commonly is seen in child care centers and in areas of an institutionalized care like nursing homes. In the laboratory, we can detect this by doing both bacterial culture and also doing a toxin test. It's really important to diagnose this disease quickly because the faster you can start the patient on volume expansion, the more you can protect their kidneys. And also there's some indication that if you treat these patients with antibiotics, you can make it worse because it's thought that when you give them antibiotics, you actually kill a lot of these bacteria and release a lot more toxin at one time, and that can cause even more damage. So if you can identify the disease quickly, you can just start them on fluid replacement and not give them antibiotics. But there are actually 2 types of Shiga toxins, type 1 and type 2. Type 2 is more often associated with the hemolytic uremic syndrome and seems to cause a more serious illness. We do